Can I do that?
Yeah, second.
Okay, sorry. Okay, it's been sent to consent. So,
Great. One thing on this is there was no CER submitted for this since it was a renewal. So I know that you had mentioned CER. All I have here is a purchase requisition.
Contract renewal.
So
As long as you have the contract renewal, that's all that's necessary.
okay,
contract renewals every month.
making sure I didn't have to do something else. All right, guys, thank you.
Hey, Kerry, can you come over and stop in my office for a minute?
I'd love to.
And I know you would. Just a comment about the camera.
Sure.
Okay, moving on with the agenda, we'll go to the financial statements and we'll start with Barbara. Correct?
Okay, you're gonna leave the surgical supplies for,
We can do that.
Oh, we're gonna do that now or?
There's nobody here waiting on it, so it's fine.
It doesn't matter. We can wait.
No, okay, we'll do it after we're done with the financials.
okay. Then we'll start on page 16, which is our statistical page. And our average daily census on acute was 8.5 patient days. That was 5.3 for acute and 3.2 for swing bed. We continued with a good volume in swing bed for the month. Year to date is 4.3 acute and 3.7 for swing bed, with an average census year to date in September of 8, and in the prior year we were at 5.3 total. The SNF only ran the census of 48.8 for the month. Year to date, they're at 50.3, and prior year to date, they were at 57.7 patients per day. The ER in the month only saw 527 patients. The budget was to be 612. The prior year was 646.
Barbara, before you leave that long-term care, are we going to be doing anything different on intake in the SNF? I mean, we've been down to 48
Well, I know.
residents for 2 weeks.
I know. I pressed Sally on that to get out and start really hitting the calls on this to try and identify more people. It's just, I told her this is way too low. She's got the staff in there. There's no reason why we can't take on more. So I'll be meeting with her later this afternoon on that.
Thank you.
Okay, and back to the ER. Year to date, they've got 1,689 visits, and in the prior year, they had 1,943. Of those patients for the month, they admitted 3.04%. In the prior year, they had admitted 3.41% of their patients for the same month. The outpatients were 987 for the month. Year to date, they're at 3,517. And in the prior year, they were at 3,359. The clinic was 1,632 primary care visits for the month and 311 specialty visits. That's exceeding their budget in both categories. Year to date, they're at 4,774 visits for primary care. Prior year, they were at 4,320. And in the specialty visits, they've had 910 year to date.
Barbara?
Yes.
I want everybody to kind of take note of the clinic visits, how they're up, and when they're up, the outpatient visits are up. We're getting a lot of our outpatient referred patients from our own clinic.
Yeah.
So it makes a huge difference. It drives it drives our other areas, basically, if the clinic is up.
Can we build another clinic?
We have some plans. We have some ideas we've been talking about. We'll talk about later.
On outpatients or surgeries, there were no inpatient surgeries during the month and 5 outpatient surgeries, and they had 44 scopes. Year to date, they've had 9 outpatient surgeries compared to 8 in the previous year, and 115 scopes versus 122 in the prior year. The retail pharmacy filled 3,307 scripts for the month. Year-to-date, they're at 9,963. The prior year, they were at 10,737. And in the month of September, the mobile van had no visits, but I know that they've had visits in the month of October, so there'll be visits in there this month.
And we're getting the MOU put together with the school district, so they're trying to get that off the ground quickly. So I know Greg's working pretty hard on that.
How are the nursing visits being counted?
They're not being counted yet because we've only had like 2 or something.
Okay,
Where I would like to see them counted, Greg actually has a sheet for the mobile clinic and a sheet for the regular visits, and he uses, actually, we don't have a separate sheet, am I correct, Barbara, for the diabetic clinic? Of count.
We
I
would
think it goes
have,
in with the others. What I would like to see in this particular case, if we're talking about visiting nurse visits, is to have it in with the mobile clinic. That's how we're going to bill it. Basically, we're going to bill it as a clinic visit, but the same way we bill them, the mobile clinics, both the NPI and obviously the tax ID is the same, but the NPI that I'd like to use is the one for the mobile clinic. The situation there is we actually have a contract that's being written, and that's already been those questions have been asked by Kern Health Systems, and I gave them an answer this week. So it would probably show up under the mobile clinic, and then those mobile clinic dollars can come up separately. We do those separately, and those could go in there. Greg has shown what's for Kern Health Systems and what's for other. So I would like, is that okay, Barbara?
that's fine with me.
I think it doesn't make sense to me to run into another separate clinic for it. It doesn't make sense.
and that's fine. I just wanted to know where we could see that and see what kind of visits.
Mobile clinic is what I have planned.
Perfect.
Okay.
Thank you.
But I'm only aware that they've had 1 visit since they started doing it.
Yeah, I don't know. I know she'd identified a second patient. She's got several patients I think they identified. I don't know if she's actually gone out to see them yet. I haven't heard.
Okay.
I think there were like 6 of them that she said Greg had identified.
Were there any other questions regarding the volumes or the statistics? We can go to page 11 then. That's the revenue and expenses for the month. Our revenue in the month of September was $9,532,000. The prior year for the same month, it was $9,710,000. Quite a bit below what we were last month. After our deductions from revenue, we ended up in our other operating revenue, we ended up with $2,594,000 total operating revenue. The prior year, it was $2,398,000. After all of our expenses, the monthly expenses were $2,473,000. The prior years were $2,274,000. We ended up with a net operating surplus of $120,000. And after our non-operating revenue, revenue and expenses, we ended the month with $169,305 surplus. And the prior year, we were at $121,767. So any questions on the revenues or the expenses for the month?
Well, it's kind of a wash in a way. You know, you budget for 9 or 10, make 9, but then you get a net surplus that's over your budget anticipation. So.
The following page is the year-to-date. For the year-to-date accumulation of the 3 months, we are at a surplus of $295,169. Prior year, we were at $119,788. During the month, there were no IGT payments and no IGT receipts. Are there any questions with the year-to-date?
Well, we said the year to date is looking pretty good so far.
So far. The next page that we usually review is page 22, which is the days in the accounts receivable and the days in the accounts payable. In accounts receivable, we're at 70.6 at the end of September, and 44.49 days in accounts payable. There's not any question.
I think it was mentioned the other day that we have a lot of, was it over $1 million still unbilled at this point in time? Is that correct, Chet?
That is correct.
Okay, what's the process that we're working on right now to get that stuff billed out?
The current unbilled, is that what you're talking about?
Yeah,
The stuff that's not coded and not complete yet? Or?
I just remember you mentioned it the other day, so.
I did, and I haven't looked at it since Monday, I don't think, but on Monday it was like 1.2, 1.3 million.
Okay,
We're working on it daily.
yeah,
Every day.
That's not the only unbilled. What you want to do is look at the last sheet in this report. I mean,
which page?
in here, it's on here, right, isn't it, Barbara? The AR sheet? No, I guess it's not. There is a sheet on this report that whether we include it or not, and Heidi can. You send that to her, right, Barbara?
Yes.
That AR sheet?
I'll take a look at it then. If Heidi's got it, I'll take a look at it. Thanks.
But you can look in the system every day and see why,
Yeah.
you know.
Where
And
it is.
basically, there's also, Barbara, over $1 million outstanding in addition to that, okay,
Which page? Barbara?
or
18.
almost $1 million for the SNF. That has to do with the TARS.
Are you talking about page 18?
Page 18, let me look.
Okay. I think that's what he's talking about is page 18. 18 at the bottom.
Yeah, okay, so this sheet tells you about your AR. See your total, now what you've got, for example, this says that your unbilled revenue is at 5.15 days. See that down there?
Yeah.
Number of gross days in unbilled revenue.
Uh-huh.
Look what it should be. Should be no more than 3 days.
Right. That's why I was looking at the target up above is 70 and we're, our target is 60, but we're running at 70. So,
Yes,
okay.
Which
so
is
at any time, and actually you can look at it, the system anytime, but we actually put this on there so you can see it. Now you say, okay, where is that? Okay, look at the all services. They're over 70, we're at 70 days.
Yep.
Okay, look at the inpatient. That's over 80 days. The outpatient's over 72 days. And so you can see the golds there are 60 days each. And then the long-term care is at 59 days. And its goal is 50. I can tell you that all of these things, let me start with long-term care. We normally in the past have run around 30 in long-term care in the 30s. And so that's been up a little bit. And I couldn't tell you without having an analysis why that is. You can see the others. Actually, the outpatient is usually because it flows through quickly, is usually up a little bit, but the inpatient at 82 days is also very unusual. Now, if you want to talk about, go down there, it's the self-pay is running at 15%. We say 10, but it usually runs a little bit higher than 10.
Yeah.
You can see there's really no charity care. The bad debts are running a little higher as well, 2.42, 2.53 versus 1.95. On the other hand, because we get the supplemental money in, the collections as a percentage of net revenue for the current month was 149%. So we got 49% more than the charges.
Yeah.
Okay, and you can see it's 100. So so far year to date, we're 20% extra for the 3 months.
Yeah.
Now, October's going to make that go down like a rock, but that's where we are at the end of September.
Okay.
You can see the insurance there. That's the biggest problem on the, you see it's 35% and the goal's 15. It's more than double.
Wow.
So the insurances were not doing very well on collection. That's where we have our biggest problem right now. The Medi-Cal at 16% is below. The Medicare, look how low it is.
Yeah.
Those always do well. Our commercial insurance is where, and our HMOs are where we're not doing well at all.
Okay.
We also still have a problem with denials with that new system. I know it's supposed to be the cat's meow, but you can see the current month is okay, but the 4 months is at 3.87 versus 2%. That's the new system. That's the denials on the new system. Okay, so we're still running double. Now also the rebills, because of that, you can see for 3 months, 14, we're still having to rebill 15% with the new system of all of our bills instead of 4%. So, and I don't think our people have changed what they put in dramatically. It's been like that since we put the new system in. So you know why I had some doubts about the new system. That'll tell you the whole story right there.
Okay.
It is better than it was when we started with the new system.
Yeah, no, it's just taking time to get it worked out. I know there were issues with as I understood, with the way the system was set up and those kinds of things, and those they've been working on that. I understand that. So I was just trying to get an understanding where we're up to date on this stuff. That answers my questions. Thank you.
Hey, Barbara. Barbara,
Yes.
on the building, I know you know this, and I know we don't do it, but the ambulance company, anytime there was a car accident, whenever Bond was running it, the minute they picked a person up, he turned an insurance claim in to the insurance. They pay 100% of what you bill. Normally, it's only up to $5,000. However, if we build, when we get someone in the emergency room, if we build immediately, there's got to be a way to do it. We would get at least 5,000 or more from full price, 100%, rather than waiting and getting Medi-Cal or Medicare and getting $600 or $700.
One thing you've got as a problem, Gene, is that with our billing, you have to have the physician's notes, and those guys aren't real quick.
Okay, but to bill the insurance company, you don't need anything special. You just send them a bill.
All I'm saying is it's a situation where we normally wouldn't send a bill, or they would actually send it back to us without physician documentation.
Because you can't
Okay.
finish the coding without that. That's the problem.
Okay, but if we just send them a bill, then we're first in line and we will get it once we get it finished. It's just something to think about.
There's very differing thoughts on that, because I know years ago when I was in LA, there was the kind of thought that what happened is that obviously after the first of the year, when you had all the deductibles and co-insurances kicking in, what happened is that companies would intentionally hold back on theirs because they let somebody else be first, so they get sucked up with the deductibles and so forth, and then they would wait for the insurances to kick in later. So I mean, there's different schools of thought on that. So, and the ambulances do get paid a little differently than we do, so.
Definitely.
As long as they stay within their target window, the whole idea is you're supposed to put an automatic target for the bill to drop.
Right.
It won't drop in that automatic target if you have anything missing, meaning like coding or doctor's notes, whatever it might be.
Yeah.
But that's why we use 3 days as the goal. Automatically, if everything else is like it's supposed to be, those bills will drop in 3 days.
Right.
Okay, thank you.
This is the standard, right?
Okay, go ahead, Barbara.
Any more questions?
No?
The following page, 23, is the cash flow page. We started with $799,000 cash balance. We've collected $3,773,000. Now there's a big jump in the miscellaneous cash in this month, but what we received was one of the CEC checks, or one of the checks from back from the CEC for the train project. That was over $1 million.
So there's still, again, as we discussed yesterday, there's still some that's hanging out there that we're waiting for CEC to pay.
367.
Yeah, about 350,000, 360,000.
Okay, all right.
Yeah.
one more update on that, Barbara? You want to give them that update? Tell them when we will get it?
Not for at least 12 months after the end of the project,
What?
because within the terms of the agreement, there is apparently a stipulation that you have to show your savings from the time the contract is completed.
Yeah,
You have to track your utilities for 3 years,
right.
then show your savings in that year. And when you send that paperwork in, you will collect that final payment. But I just found that out yesterday.
Wow.
Just so you know what I have planned, we've already paid it. We paid it in September. And if the board approves the resolutions in the next board meeting on the 4th of November, I will go ahead and put that into my file for reimbursement. So once the final purchase of the bond agreement is signed and that money comes in, I'll reimburse ourselves for that if I need to, while we're waiting for CEC to see if they'll even do it. So I'll get that money, but it'll still take until the purchase agreement for the new bonds goes through.
Is the reimbursement tied to the savings?
Somewhat, yes. So I'm not sure because that's what they want to see is I guess the projection was that the savings would make the payments on the bonds.
Correct.
And so far, there's not been a significant change in our Edison especially. And so.
Well, again, because there was such a lag between when the lights were done, when the boilers and the chillers were replaced and stuff like that. So we didn't get a full year's worth.
Right.
I will say I have kept that. I put it on in the back page,
Yeah.
the packet for the building and planning. It's been about 54,000 since the beginning,
Right.
but it's not been that much.
Yeah.
Well, the Tesla project is going to make it look like we've got a lot more savings because we're going to save more money. How does that affect the bottom, or does it?
What it is that's the payback, Gene. That's how we pay that loan back, is by energy savings. So right now, when they look at it, let's say it was I think the one that Train sent to them, I was told, their first pass, which was just last year, was going to be 40 years to pay it back. They didn't, what we originally said we would do is pay it back in 17. So they're asking Train, why isn't it like that? Or are they asking us, why isn't it like that? And in my opinion, probably what's going to happen until they get to something reasonable, we're probably not going to get that last payment.
Okay.
Let me ask you a question. When we look at the savings, are we only comparing the hospital's bill? We're not looking at all of the other bills for Edison?
Only the hospital bill.
Okay, all right. Because like I said, because those other ones obviously weren't impacted by the savings, right?
Right.
Okay,
No, it's just the main hospital bill.
okay,
Okay.
And they
Thank you.
also have the propane bill too. That's part of it.
yeah, right.
Our total expenses for the month or payments out were $2,871,000. We did have some bond interest that we had projected we would be paying, but because we've already funded our next payment, we haven't had to put any money towards that. So there's no payment there.
What was the excess on the other? There's like $400,000.
The excess on what?
Well, we paid $1.2 million for other expenses.
Oh, well, we had some other funds come in. There was some Kern Health money come in, some NDPH funds came in.
That would be cash receipts.
Yeah.
I'm talking about expenses.
Oh.
That's the 300,000. We paid that in September.
It's anything that doesn't fit the other two categories, which is a lot. Your,
we paid the 360,000. That's probably the one biggest thing, isn't it, Barbara? That 360?
What was that for, Chad?
That was for Train.
Oh, okay.
yeah, we did pay 360. It was 367.
Gotcha. Okay. All right. That pretty much explains it. All right.
So we ended the month with $2,921,000 cash on hand. Any other questions about it?
No, this is best cash position I've seen in years.
One of the things that's important in this one, if you go down to the next page, it takes, you see the September there, that's actual, just coming out the page that Barbara just did. There's the 2,800,000 down at the end. See that?
Yep.
Okay, now look all the way across and you can see what the other months are projected to do.
Yeah, I remember when that report used to be zero, negatives all the way across. There's no beginning balances. I know you should
Yeah.
pay crazy.
Now you know why I believe we can make the payment for the bonds.
Right. Definitely. Okay.
Okay. The next page is 25, and that's just the debt service page. The current ratio is 0.32 of the 1.25, and the total ratio is 0.53 to the 1.4, which is under the current bond covenants.
I noticed obviously the debt service ratio here on a year to date or
Yes.
prior months year to
This
date.
year to date, yes.
Yeah, it was 4.2. So obviously this is the audited number, correct?
Yes.
Yep. That's what I thought. So that's the real number.
Yeah. The following page is, again, relates to the current bond covenants. Next payment is in February for interest only. The payment's $38,588. And on the bottom section, you can see we have $39,346 in the account to cover that payment. We've also spent $38,371 year to date in capital equipment.
And the February interest payment you already made, right?
Yes.
Yes. Yeah.
No, this is February 2021. The last payment was the August payment of 20,
Oh, okay, I see.
which was interest and principal.
Okay, gotcha.
They hit every August and every February.
February, right.
That's why they're asking me on the bond, new bonds, what do we pay? You remember they said, what do you pay? There's what we paid August 1st.
Yep.
1.475. So almost the 1.5 million that we were talking about.
Right.
So when the board adopts the resolution for the bond refinancing, now is this sheet gonna go away or no? With the Cal mortgage?
Yes.
Actually, it'll be the new sheet,
Oh, a new sheet, okay.
new bonds.
So, yeah,
This will go away.
I've gotten so used to seeing this sheet since the very first time I ran for the board.
And that's it for now. That's true, I believe.
Okay, any other questions for Barbara, Jean, or?
No,
Okay. Okay, Chet, you're up now.
Yeah, the variance analysis is not totally complete. I will have it at the board meeting so you can read it. But you were sent out the product line analysis separately from Heidi. I hope if you have that.
It'll be a separate page.
No.
Everybody got that?
That's okay. I've looked at it.
Are you sure?
Yeah, I'm good with it. I saw it on the computer. I just wasn't
What
really
page?
in the packet.
what page is that?
It was an extra.
It's actually a separate item. It was
Okay.
it's on there. It's on what Heidi sent out, but it's a separate item.
Yeah, it's not in the packet, right?
You have to log into that particular attachment. I'm going to start with that, and we're going to look at med surg first. So in medical surgical, even though we've had a pretty robust census in medical surgical, if you look at the top of that in the month of September, we had 257 days. That includes acute, swing, and ICU. It has also other ancillaries in there that are used, and the budget was 174. If you look at the year-to-date, it's 739, and our budget was 574. So that's looks really good for the volume. On the other hand, if you look at our labor and supplies and other, the costs were substantially also above budget, 319,000 versus 257. So although we had, and don't get me wrong, it's to a certain degree, it's a step variable cost, at least the labor is. Supplies should be up as well a little bit, and probably not double or as much as they were. But the situation is, we have that difference between 257 and 319. That put the gross profit below what we even did at 107. We had on the budget at 174. It was at 177 versus 214. The other, and even this was even though the deductions from revenue were down a little bit at 50% versus 53% on the budget. So we lost for the month of September in that inpatient service, 183,000 when we were supposed to lose only 75 according to the budget. Now in the year-to-date for 3 months, we've lost we've lost 537,000 where we were supposed to lose 157. Again, all those months were pretty good months as far as the volume is concerned. The real problem, there's a positive and a negative to that, because the way we're paid on a lot of those patients are diagnostic related groups or per diem. You can see that our per diem was 2,723 versus what our budget was is 2,900. That part is a positive. So the money coming in, that's why you see the money coming in like it was. That was pretty good with that variance. The only problem is what our allowable cost is, our cost. In that particular service, we are being paid about 2,200. I think that's about what it is, Barbara. You can correct me if I'm wrong. $2,200 per day in that unit, and it's actually costing us about $2,700 a day.
Well, the issue really, from what I'm looking at here, Chad, is that obviously volume was up by almost 48%. Yeah. But yet, look at the gross revenue. The gross revenue is actually less than budget. So clearly, there wasn't, you know what that is? Whatever we had in there wasn't billing anything. You know what it was? What's that?
We kept the swing bed patients from COVID over there. Yes, they don't get much in. They don't get much in the way of ancillary service.
Yeah.
And their per diem is adjusted.
But wouldn't there be wasn't there an additional bump if we billed those as COVID patients? There should have been actually.
Yeah, it was. But let's say, for example, they pay us $450. Okay, you're going to get a bump of 10% instead of so it's still a long ways below our cost. Does that make sense?
Yeah.
So it's COVID patients, although I like them there. And overall, you need to understand, those patients, even though we classify them still as long-term care, the cost report does not.
Yeah.
So the Medicare and Medi-Cal cost reports are going to call them acute patients.
Got it.
That's why you go down and you get a better rate overall at $2,700 than that's in cost. Okay, and they're going to pay for each one of those where they would normally pay in the SNF, they would pay about $450 a day. Right. Okay, actually that's for the non-Medi-Cal. Medi-Cal actually is going to get about $280, I think it is right now, Barbara. Mm-hmm. Something like that. $280, about $280 a day. That's what we get in the SNF from Medi-Cal. And here, from Medi-Cal, we're going to get a DRG from Medi-Cal now. If the Medi-Cal's primary, most of the time Medicare's primary here. If it's Medicare primary, we're going to get the per diem, which is about $2,200. If it's Medi-Cal, that's a DRG, and our DRG doesn't vary. It's the same for every patient. $6,600 is what we would get per swing bed patient if that was Medi-Cal primary. See how intricate it is what you classify them as?
Right.
So again, I'm not sure we take all those things into consideration. We just take what the doctor wants to tell us they are.
Right.
And so we go from there. But it's not, we can still throw patients in there and we're still going to see more money, but we're not going to see a profitability better.
Yeah.
Okay. Let's go to the SNF and you'll see what I mean. The SNF actually was way down in their volume, which I've grumbled about. See that 1,463 versus 1,705? But go down and look at their expenses. They control their expenses for the most part, with the exception of supplies for the month. So what they did, because they got the gross profit higher than the budget, they actually made, again, their volume was way down, but they actually made profitability wise 38,000 versus 40,000 loss in the budget. If you go down to the year to date, you'll see pretty much the same thing. They made 75,000 versus 100,000 loss in the budget. Now, let's go down to the payment, because that's important. See the 451 per cost per visit?
491. 491, yeah.
Well, the 451 is right across next to it. 451 is the budget.
Oh, okay, Joe.
Okay, we budgeted 451. That's what I said. You know why? That's what we're being paid.
Yeah.
Well, actually, we're being paid less than that. I shouldn't say that. That is the cost, okay, that we projected. And 491 is what the cost really is. Now, the Medi-Cal payment, what did I just say? $280. So although it looks good, you got profitability on the books for that product line, you're losing approximately the difference between right now 491 and 280 with every resident day, because that's what they're paying. And of course that goes back 2 years. But I will also tell you that they have a cap, and the cap's about $450 right now. So even if we went higher and the time went along, which it's going to, we still couldn't get more than the cap. It's costing us more than the cap, although we're showing profitability on the financials. Does that explain that? That's just the way it works. That's the way it works. Yeah, it is how the state looks at it. In other words, they want you to do a better job of controlling your unit cost. Does that make sense? Not controlling your overall cost, but controlling your unit cost. And then you'll get the money. All right, let's go to ED. ED is, you can see there that it's down a little bit from budget. It's going to be down a whole lot more from budget when we put October in there. But both on the month of September and a year to date. Okay, if you go down there, you can see that they do so many ancillaries that they just drive the cost up tremendously. Okay, so the cost per day, we said was going to be $690. What the actual cost per day is at the very bottom. What the actual cost per day is $882. Now they're going to show a ton of profitability. Okay, but let's talk about the ER. Most of the ER is about 40% of it is Medi-Cal managed care. About 40% of our ER utilization is Medi-Cal managed care. And in Medi-Cal managed care, what we get are two things. The first thing we get is the same as we get, which is about $500 to $600 per visit for the upfront payment. So if you're looking at the upfront payment, we would really be hurting for dollars. However, at the end of the year, outpatient Medi-Cal ancillary service, which this is considered to be one of, gets up to their allowable cost. Their allowable cost right now, as it's saying, is $690. So we'll stay at 690 for year end, even though our current cost year to date is 882 or somewhere around there. Although they will come up some with that and pay the difference. In other words, if our allowable cost goes up to some degree and our payment is still only 650 or 690, then the situation will be that they will pay us that difference between the two. We do get that at year end. It runs about, Barbara, after we make that report, and I know we've got Matt doing it for us now, it was about 200,000, I think. I know when I did it, it used to be about $200,000 a year for that difference that they pay us at year end. The rural health clinic. The rural health clinic, you can see, is doing tremendously with their volumes, both on a month and year-to-date basis. They're also doing, we also actually have a higher gross revenue. To look at that, you can see how that runs. We've got a slightly higher labor, but we've got less in expense. We've got less in supplies expense. So you come down to the end, it really comes pretty close. The net profit is 433 versus 437, or 457 budget, because of the unit cost or unit revenue, if you will, unit profit based upon the actual units. Now, if you go down to the bottom of the page, you see that we projected our cost to be 243. Why did we project our cost to be 243? Because they're paying us right now. Again, most of the patients over there are Medi-Cal managed care. They're paying us right now about $260 a visit. What's our cost really right now? $225. So the more Greg puts in volume, the more he has a situation where, now this is again as an upfront issue with Medi-Cal managed care. The situation there is we get about $60 a visit, just like you would on a patient going to a doctor's office. And you say, how can we bundle and charge that much? You know, but what really happens is they come back, what our cost is, and pay us $260 a visit. If we had that, and actually that's Barbara showing what we got paid versus our cost, right, Barbara? She does that report every year, and it includes crossover patients from Medicare. So what happens is Barbara files that, and we get about $200,000. You start dropping those charges, and that's going to drop what we can get at year end dramatically. I'll go to the next one. Surgical
Hey,
services.
Chet, on that, the telemedicine, if I'm not mistaken, Dr. Lopez or one of them will talk to patients on the phone. We do that, right?
We
do
do
we bill
what?
the same? Telemedicine, telephone.
We do telemedicine, yeah.
Okay,
Oh, yeah,
so
but mostly,
is it billed the same as a regular visit?
actually, what it does is it doesn't save much cost per unit, okay? But what it does is we get it, just if we're doing it on telemedicine, we get an extra 20%, approximately 20%.
Okay.
Okay.
Thank you.
So it's actually, and also the waiting time, you know, there's not as much waiting time with telemedicine. In other words, your provider, your doctor, instead of having a patient wait out in the waiting room and that doctor spending time, whatever, as soon as, the way it works, they've got their time set aside. And so as soon as we have them on the screen, or it comes up, they're going to be on the screen. The biggest problem with the telemedicine, where we do it remotely, what that means is the doctor, let's say, is in Bakersfield. We have patients that don't show up. Quite a few patients that don't show up. And we still get charged for that if they set aside their time. So if they've set aside 30 minutes, let's say, for a visit in Bakersfield, and we don't have anybody going to that visit, we will still have to pay for that. And the visit price is around $200 per visit. Okay, so that's one of the biggest problems we have is our no-shows.
When Chet, I was just an example. I was listed as a no-show yesterday
Yes,
from Bakersfield from a heart doctor.
yes.
They dial 661 and then my phone number. And
Oh,
so,
yeah.
and so they said I didn't answer the phone, and I called them back and explained, and they sure enough, they dialed the wrong number. So that, you know, between 760 and
Yeah.
they're used to dialing their own area code.
Yep.
Well, the real bad part is, let's look at pediatric psychology or psychiatry. Pediatric psychiatry, we don't have that many, but we do have some. And we do have a pediatric psychiatrist. I've seen where of the 3 patients we have on a day scheduled for that particular psychiatrist, that pediatric psychiatrist, 2 of them won't show. So we end up maybe getting, even after all this, we may be getting less than half, 1/3 of what we should be getting because of no-shows. Now, it isn't that bad with the adults, they're better. Anyway, surgical service. You can see the surgical service had a pretty decent volume between, in the month of September, between the surgeries, which was actually good. We had 9 surgeries. I'm not talking about endoscopies, I'm talking about surgeries. But with the surgeries, we had endoscopies together, we had 49. So the revenue was up, and it was up pretty good. But look at the expenses. Look at the labor, for example. The labor ate our lunch. We had 23,000 budgeted for labor with 47 patients. We used 34,000 with our patients actually at 49 with their procedures, I should say. So instead of losing $83,000, we lost $165,000 because we didn't control our expenses. Even when our volume went up a little bit, we just ratcheted up our expenses. Doesn't work, especially when you normally don't have that much. Now for the year to date, it's not as heavy, or the volume. You see the volume's down there, and the revenue is also down. And look at the expenses. The expenses, we still had a situation where we actually were above our target for even more patients and for more procedures in almost every category except other. So for the year to date, we've lost 440,000 where the budget was to lose 280. If you look down at the bottom, you can see we said per surgery. Now, what do we get? Most of these are endoscopies. What do we get per endoscopy? Per endoscopy, we get about, because this isn't a reimbursement at year end or anything. For endoscopies, we get about, well, actually, there's a little bit that is. I shouldn't say that. For endoscopies, we get about $2,000 after we get the year end in there. But our cost that we hoped was going to be $4,000 is $6,000. So it costs us, every time we have a patient in there, it costs us 3 times what we're going to collect. 3 times what we're going to collect. So if that volume doesn't go up, I mean, we're throwing over $100,000 away in the trash can every month. And that's real money. It isn't made up anywhere. Okay, let's look at the referred outpatients. You can see the referred outpatients are actually a little bit less than our budget in September. They actually ran a little bit less even in revenue, like just to match that. And the contractual allowances are pretty close. The expenses they kept pretty well in line, pretty close. And they kept, actually that caused the gross profit to be up. Then they took the overhead, which actually is going to match on the basis of the actual direct expenses. And so they actually were supposed to make 95,000 and they made 94. So they ran pretty close to their budget, even with a lower volume. For the year to date, you're going to find the same thing. they actually made a little bit less, 243,000 versus 304, because their volume back in August and July was as low as it is. If you go down and look at the cost per procedure, and most of these procedures really are charged more than $100 per procedure. The cost per procedure is supposed to be 56. It's up to 65, and we get reimbursed right around what we're having in cost right now. 65, 70 bucks a procedure is pretty close, pretty close. The rehab services actually, you can see came up a little bit, but not nearly what we had in the budget. 1,000 versus 1,500. You can see the revenue is down. I'll go down and look at the expenses. The expenses were way down. They kept those expenses down from what we had before with the higher volume. But that also caused the gross profit to be half what it was budgeted. The overhead was about half, a little bit more than half what it was budgeted. But they made 468 bucks because they kept those expenses down so low. Even though their volume was down, they kept the expenses, especially the labor, down. And so 468 fell to the bottom line in September, where we said they should have made 7,413. You go to the year to date, it's worse because both the months of August and July were worse. We were losing money. So you can see for the year to date, we lost 15,000. We should have made 14,000. We're down to the little item at the bottom. And the item at the bottom says, the budget says we should get $53 per treatment, if you will. We actually, or we should spend, $53 per treatment. We're spending about 59, and I will tell you that in most cases, again, we get some year end on this for the Medi-Cal, we're getting about 59. So we're not losing nearly as much because we're keeping our actual cost halfway in line with what it should be. Retail pharmacy. Retail pharmacy, you can see, is up a little bit for the month of September over the budget, but depending on the nature, the mix of pharmaceuticals, the gross revenue was only 175 versus a budget of 190. So that really depends on the nature of what we're actually dispersing, filling and dispersing, and how much is brand and how much is generic. I'll go for that as well. That's really on the cost side. The 44,000, you can see they were over in labor. They were about what they should have been in pharmaceuticals, 112. It got down in the gross profit was only 11 because of their lower than per unit revenue and their higher than per unit labor. And so we had the overhead basically was actually pretty close, a little bit higher. So we lost $8,438. We should have made 11,000. For the year to date, it'll track the same way, except it goes down to 41,006 loss versus 34,000 profit in the budget. The unit cost of 56 versus 53 makes a huge difference in the retail pharmacy because they don't get any, they're not part of our critical access. They don't get any year-end reimbursement. They don't get any cost reimbursement. If they don't make it on the front end like other business, that's it, folks. So that what we do is we lose right now. Every time we fill a script, if we're filling it the way we're filling it, even our volume went up, we're losing probably $2 or $3 a script for our filling. So that's the story behind all of our product lines. And I'll stop there because I think you've seen enough of the other stuff.
Okay, any other questions for Chet on the product line?
I can actually do the cash flow variance if you want, but we've looked at cash, so I won't unless you tell me you want me to. Want to do it?
Okay. Dean, do you want to look at it, or are you okay with?
Gosh, that's great. So
Nope,
Okay.
I'm fine with
Okay, we're good, Chet.
Uh-huh.
So, which one are we on now? I lost my place.
I think the local vendor agent.
Oh, page 29.
We were asked, by the way, Barbara, we were asked a question about this yesterday that said there's a lot of money in accounts payable to the local vendors. Would you please verify that's not true when you do this?
Outstanding, we have $11,000. Most
Right.
of it's current.
Right? That's it, Gene, that's all there is. Outstanding to local vendors is $11,000.
Okay, no, Chet, what I was referring to is I see where we pay $50,000. Greenbaugh, I use them for an example. And it's from 2018.
Greenbow, we have not been paying as current. You're right. That's not a local vendor.
Okay. What I want is a list of people we're not paying. Are we paying everybody 30 days after they're due?
No.
Or 60 days after they're
Our
due?
goal is 60, but we don't even hit 60 on some of the very large accounts.
Well, why aren't we paying them?
Because we're trying to keep our days and our cash available.
Yeah, we want to keep it available, but if we don't,
Our days and our cash are where they should be. Our payables right now, as of this morning, we're at 1.5 million total.
okay, another
You
example.
don't want to get it down to nothing. You don't want to get it down that way.
Okay, but it would be nice to see. Now, we were paying, or we still are paying for the Elections Bureau or whatever you call it.
That's true.
From 18. Why?
Because the county doesn't mind.
Does that show?
The way you manage payables is not to pay them off. The way you manage payables is how many days you have outstanding and can you get their goods. Barbara's a wizard. She actually does a great job of getting everything we need and still keeping some of those things out. So where we stand, if you look at what she just told you about the days are 44. Am I correct, Barbara?
Correct.
Aren't they 44?
Yeah.
The average, Gene, for most hospitals, actually 45. 45.5 is what I have on a year-to-date basis. It's a little bit less than that on Barbara's page, but it was actually 44.49. Okay, so most hospitals run 60 days. If you're running below 40 days, that means you're paying your bills too fast. You're not keeping your cash.
Well, if some of the vendors, like I see we pay them $100,000 a month or more, would it be advantageous to us to pay them on time and get a discount or something along those lines? Can you do that?
They won't give you a discount. Once in a while we can negotiate something, but not very often. If you call Memorial, I guarantee you that they would tell you that their days outstanding in payables is more than 60. More than 1/3 more than ours.
But I would still like to get with Barbara, just take a few minutes and see what else is, just a basic picture of it. We don't need it for the
Well, you'd have to look at an aging. You have to look at an accounts payable aging.
Yeah.
Which is about, Barbara, you can print out one, Barbara, but you'd have to send probably the whole thing because it doesn't actually, because there's so many vendors on there.
Yeah.
It doesn't help us.
Gene, I actually already have that for you. You and I talked yesterday about that. So.
Okay.
So next time you're around, we'll sit down and go through it.
That's not going to happen. We're going to keep it at 44 days.
Chet, if it seems like some of the questions asked aren't very smart, it's
We're even
because
going
you
to
know
have
more than I do.
We're going to have a bigger problem if you approve the loan, because to make the loan payments, it's going to have to be squeezed even tighter. And I noticed yesterday that we don't even really know until I tell you where we are and what we spend on the project. Right. That needs to be looked at before we spend $1. That item needs to be looked at. I managed the construction over at Tehachapi like that, and the board was very sensitive. They signed off on every invoice after my signature, okay, and after the CEO's signature. And only then, because they were hit so hard by change orders. we're not doing that. We can't if we're gonna budget like that, it's gonna cost us $50,000 for this stinking project. So we've got to put more controls in our project.
We're going to. Now, can I ask you a question? Your thing normally, we hear you duplicate coming through too. Do we have to pay you twice as much whenever we do that?
No, that's part of the job.
Okay, we'll move on to the contract renewals, and I guess that's you, Barbara.
Okay.
What page is it?
30.
30. The first contract on the list is ADS, which is Advanced Data Storage. They are the company that comes in, picks up our PHI and destroys it to keep everything compliant. And the charge is based on the weight of whatever it is that they pick up. Alimed Healthcare is a peer review service, is various rates per case.
Barbara, can I interrupt you for a second? I went over that too fast. Gene, I'm going to make a recommendation. My recommendation, if you approve the new debt, that every invoice for construction is brought to the Finance Committee for you to approve before it's ever paid. And every new contract for construction, new invoice, and we're doing some of that now, but it's going to get very voluminous, is brought to the Building and Planning before it's approved for purchase. That's my recommendation to you, just so you know.
Yeah, maybe we can cut more corners that way, because I know there's, well, no reflection on Bob Easter Day, but maybe once in a while we can squeeze in a little local labor.
I can tell you that over at Tehachapi, we're going to run out of money in 90 days. We went a year and a half more.
Cool. We just need to watch what we're doing.
There's a little stamp on every invoice and a little stamp on every purchase order, signed by the architect, signed by the manager, like Bob, signed by the CEO, signed by the CFO, and signed by the board. Nothing went out until that.
Hey, Chet, you mentioned two places. You mentioned the Finance Committee, but then you mentioned Building and Planning. Which one is it?
Actually, this one would be Building and Planning.
Okay.
Well, the Building and Planning, is there a vote on it, or does it, what would happen?
You can if you've got enough members. Yeah.
Well, that's it. The management is primarily building and management. At any rate,
not if you can say, for example, let's say we bring that there. You can say, no, I want this to go onto the full board. You can do that.
okay,
It's currently a full board.
okay.
It's full board meeting anyway.
Yeah, that's a full board meeting anyway. That's why Finance is only 2 board members.
Right.
Well, it's right now the way it's working. It's a transparency. Eventually, if the public has to bail us out, and I'm going to try to make sure they don't, they would see it at the Finance Committee or the board. But this one seems to be a quiet little building planning, a quiet little committee that doesn't get as much attention.
What will happen is when something comes in the paper, like it had to be, when it said we had our new building, but when we finished, we had our new building appraised. The appraisal was $58 million. And they had spent $102 million.
Right.
That's your lunch. The community was paying for the bond there.
Well, we need to get a better appraiser than that. We'll work, Chet, it will be worked out. We will account, and we won't step up too far. There's a way to do it, and we'll make sure it happens. If we get the money, we should.
Oh, I don't think there'll be any problem getting the money. Somebody will buy it. There are banks out there with our financials. I bet we have at least 3 offers, at least.
But we're out on a limb once we do it. So we got to not saw the limb off.
We agree.
Okay, Barbara, go ahead with this.
Okay. Back to the contracts.
Yeah.
California Health Collaborative, it's Cancer Registry. That's a requirement. They come in and abstract information from charts. Care Fusion is the rental, one of the rentals for the Pyxis machine that the pharmacy uses in the ER and acute. Houchin is a service that comes out of it, that's in Bakersfield, that supplies blood. It's the only place, that's where we get our blood from. Travis Johnson, CRNA. This contract doesn't actually renew until next year, but it's one of our annual review.
I'd like to make a comment about this one also. Travis is also acting as the surgery services manager. So he kind of wears two hats. We don't have a nurse in there. The only nurse we have permanent in there is Gail. We used to have an RN in there. So Travis has kind of stepped up to the plate and been able to be the CRNA plus the department manager, which has really kind of helped. He's wearing an extra hat. I just wanted to recognize that.
That's unusual, and yes, it should be recognized.
The next one is MCG, which is the Interqual Criteria Program that Utilization Review uses for all patients coming through the facility. MediaCom is just the cable TV service that we have that supplies cable to our residents or patients' televisions. Medical Solutions is a nurse registry with various rates depending upon what's used. Mesa Winds Apartments, we rent 3 apartments there for nurse registry.
Wait a minute. It's not just nurse registry.
Well, you didn't let me finish.
It's just the way you described it.
It says in the description, nurse registry board.
I know, but it's others also. It's pharmacists, it's any traveling people that we have coming through. We also have employees at times that will stay in the apartments. RX30, this is the software that retail pharmacy uses to fill prescriptions and bill them out. SiteFM is the service that maintenance uses for the hospital to keep track of all work orders and things that need to be repaired around the facility. Tyco Security Systems is the alarm system we have at the retail pharmacy, after hours alarm. Valak is our retirement plan for the employees. And Valley Children's Hospital is just a transfer agreement. There's no cost to that. We just maintain that to facilitate transfers. And then we had 2 agreements that were still pending from other meetings, and that was our Finstead's agreement and Alta Sierra Broadcasting.
Yeah, and those we agreed we'd move forward. So again, because that wasn't the one, Gary, that I was concerned about with Gary. So we talked about that. So this one can move forward.
Okay.
Do we need a motion to move that forward, John?
You mean take it off of here?
No,
Oh,
keep it on.
keep it on here.
Redo it.
Yeah, motion to put it to board consent.
Yeah.
Okay, I'll make a motion.
Okay.
Second.
Okay. To board consent next week. And the last item is the surgical supplies for Dr. Montez.
Yeah. What's going on with that?
Chet probably has more information.
Okay.
Yeah, Chet, what do you know about that one?
Sorry?
What do you know about the Dr. Montez's excess surgical supplies?
Yes, I just got that after the agenda had been posted. And what it is that we have some disposable equipment that he'd been using up there that's going to outdate very shortly. Some of it in 21, some of it, a couple items in 22. I don't think we have anything that's going to outdate by the end of December. And so we took those items, and Christine wanted to know what we could do with them. And I said, find a buyer. So there's about $5,800 worth of our cost disposable equipment there and she got about 50% offer from a firm out there that would buy those, but they want to do it fairly quickly. And so if we want to get rid of those, because they're going to outdate anyway, we're going to throw them away.
Right.
If we want to get rid of those for the 2,500 for about 50 cents on the dollar, we can.
Is it a good idea? Is
I
it a
think
good
great.
idea to do that, Chet?
Yep. Well,
It's either
otherwise,
that or we throw
otherwise
it
we're gonna
away.
eat it.
Yeah.
You're-
Okay,
what
I'll
you're
make a
doing
motion.
is the board declares it as surplus property, and then it can be done.
Okay, I need to I'll make a motion that we sell it or do whatever we're asking.
I'm good with that also.
Okay. So we'll send that to consent as well.
Okay. Just, I want to update something, the board. Last time we approved a capital request item for orthopedic surgery equipment. You know, since that was done, because again, we are under a crunch because we were trying to work with Dr. Grimes to see if we can't get him started doing some surgeries here. And as we've learned since then, there are some issues with Dr. Grimes that we probably don't want him here. And so forth. Apparently, we've heard from, he had a circulator that he was touting was the best circulator he's ever worked with. And when Travis and Gail reached out to him and so forth, he basically shared with him that he was kind of like, he's in his book of worst nightmares to work with. And interestingly enough, the two companies that we got solicited the bids for the equipment that he was requesting, I think it was Stryker and there was another one. Both of the reps for selling us that equipment told us the same thing, that he is a extremely difficult person to work with. As a matter of fact, what we learned was that most of the places in Bakersfield wouldn't work with him anymore, which is why he was having difficulties in getting surgeries done. It wasn't because of COVID and things being closed down. I've since learned that he is, in fact, doing some surgical procedures at an ambulatory surgery center in Bakersfield. I'd never heard of it before. I don't know if it's a new one or whatever that opened. So at this point in time, I really question how much of those cases that he said he still has out there, he would even be able to move here. So I have not executed that contract. I'm not moving forward with it until I think that we have a better option or a better physician to work with. So I'll keep you apprised, but at this point in time, I'm not planning on spending those dollars that were approved. So just wanted to update the board on the status of that. So.
I only know, Tim, of one other circuit rider,
Yeah.
and I'm trying to think, actually, I think he goes to Lake Arrowhead. So you might check with CEO up there and find out who they've got circuit riding.
Okay, we'll do. We'll do. Yeah, because I think there's certainly a need. As a matter of fact, in the community needs assessment that we did, and obviously the lead up with our questionings to the community, the orthopedic surgery came out pretty high. So we need to find someone that can do that. So I'm not going to necessarily take it out to say we're not going to buy it. I'm just holding it at this point. I'm not buying it for him. And so obviously we find somebody else, we may have to go back and relook at the equipment. If that's acceptable, great, we can put it through. But I'll bring that back to the committee to discuss that if and when that happens. Just, I don't want to go out and spend money that again, we're going to have issues with, so. But like I said, that was learned after we had approved that, so.
Okay,
That's all I got.
all righty, well, then we are adjourned at 10:25.
Can I make a comment, John, before?
Oh, yeah,
you
go
go?
ahead. Real quick.
Okay, if there's anybody out there listening, on the third, vote for John. Thank you, guys.
Thank you, that's the nicest thing you've said.
Thank you.
Thanks, Gene. Have a good day.
All right.
And like I said, when you get back sometime, just let me know and I'll go over that stuff with you. I think we're done.
Did you print an AP aging for
Just printed it this morning.
just a regular one?